So I guess I'll make a start. Good afternoon, everyone. Welcome to the Spring 2024 Breast Community of Interest meeting. Thank you so much for joining us. My name is Jessie. I'm a breast pathologist based at St. Michael's Hospital in Toronto, and I'm also the host for this meeting. We have an excellent program for you today. We're going to start the meeting with a lecture from Dr. Gabriela Kuba from Memorial Sloan Kettering on vascular lesions of the breast. And as you all know, we get a variety of vascular proliferations, both benign and malignant, occurring in the breast, while they represent really like only a minority of tumors originating in the breast. They can actually be quite challenging precisely because we see them so rarely. So I'm really excited to hear this lecture, and the lecture is going to be followed by a Q&A session. Afterwards, we'll have presentations of interesting cases. It's a real pleasure to introduce Dr. Gabriela Kuba. Dr. Kuba is currently an assistant attending breast pathologist at Memorial Sloan Kettering. She attended medical school in Argentina, did an AP residency in Buenos Aires, and during which time she also went to Tokyo to train at the Center Institute of the Japanese Foundation for Cancer Research. Dr. Kuba moved to the US in 2010 to work in breast cancer research for the NCI designated breast specialized program of research excellence at Vanderbilt University in Nashville. She stayed at Vanderbilt to complete an anatomic residency, entomology residency, where she worked with Drs. Melinda Sanders and Jim Simpson. And afterwards, she went on to do breast and surgical pathology fellowships at Brigham and Women's Hospital in Boston, where she trained with Susan Lester and Chris Fletcher. And it's clear that she trained with very distinguished pathologist researchers. Her research interests are vascular lesions of the breast, particularly angiosarcoma, as well as lobular lesions. And we're so happy to have her here with us today. So please join me in welcoming Dr. Gabriela Kuba.
Thank you so much. Sorry for the...
No worries.
Thank you so much for the patience. So yes, my name is Gabriela Kuba. I'm a breast pathologist at Memorial Sloan Kettering. And first of all, I would like to thank very much the organizers for the invitation and everyone joining in today. And the talk is about, as Jessie mentioned, about vascular lesions of the breast, which is one of my research interests. So in this talk, we'll review the clinical pathologic features of benign and vascular lesions. We're also going to talk a little bit about the role of immunohistochemistry in the diagnostic process. Then moving on, we'll review a few maybe challenging cases of vascular lesions of the breast. And finally, we'll touch upon the management of vascular lesions diagnosed on corneal biopsy based on contemporary studies. And as we know, the majority of vascular lesions of the breast are incidental and benign. They can involve the breast parenchyma, but also can involve the breast skin. We can divide them in two categories based on clinical behavior. So we have benign lesions such as hemangioma, angiomatosis, and this one with a funny name, atypical vascular lesion. And malignant lesions would be angiosarcoma, as we all know. The thing is that morphologically benign and malignant lesions can have overlapping features, which make them sometimes challenging. And so on one of the end of the spectrum, we have benign lesions. These benign lesions typically feature circumscribed margins. There is no distortion of the lobular units. They have blind cytologic features, no mitosis, no necrosis. And then on the other end, we have clearly malignant lesions. We have, the infiltrating pattern with the internastomosing vessels, marked nuclear pleomorphism, solid growth. They can have spindle cell or epithelial morphology. It's very frequently they have numerous mitosis. I mean, it's easily to see, and sometimes they can have areas of necrosis or blood legs. But sometimes lesions that look otherwise benign can have some features that are concerning, such as focal infiltration of the adjacent tissue instead of having like these circumscribed edges, or they may have some nuclear enlargements or hyperchromasia, or they can have vessels with an intranastomosing pattern. And so the distinction between, for example, a hemangioma with some atypical features and a low-grade angiosarcoma, or even the edge of a higher-grade angiosarcoma, can be very difficult. And so my hope is that maybe at the end of this talk, we can learn some differential diagnosis that we should keep in the back of our head. And we review these entities, each of these vascular lesions, with some clinical examples. So in the first case, we have this 33-year-old female who presented with a palpable mass. On ultrasound, it had all the features of a benign lesion, right? Oval circumscribed hypoechoic, and it's clearly, we can see on the core biopsy that we have a fibroadenoma. However, there is also this area that you can see very busy, which is a small vascular proliferation composed of these capillary-sized vessels with blunt cytology, with blunt nuclei. And this is characteristic of a perilobular hemangioma. These are typically, they are always incidental findings, and they are typically a few millimeters. They are circumscribed, and despite their name, they can involve the intralobular stroma, the interlobular stroma, or both. And they're composed of these small, thin walled vessels. And as you can see here on the left side, it's mainly involved with the intralobular stroma, but there's no distortion of it. And the endothelial cells, comprising this lesion are very blind. Moving on, we have this a lesion in a 65-year-old female who presented with a palpable mass. And clearly you can see this on core biopsy, a vascular lesion composed of these dilated ectatic vessels. And on higher power, we can appreciate that they are lined by a single layer of blunt endothelial cells, within areas concerning of, no areas of solid growth or mitosis or necrosis. So this is diagnostic of a hemangioma, in this case, a cavernous hemangioma. Now, hemangiomas can occur at any age. They present usually as a palpable mass, and they are typically located in the subcutaneous tissue. Grossly, these are well circumscribed. However, they may show irregular or infiltrative borders. And these lesions are usually cytologically blunt. However, there have been described hemangiomas with atypia or atypical hemangiomas, which are hemangiomas that have either some focal infiltrative edges or some nuclear hyperchromasia or internanastomosing vessels. However, these have shown to have the same clinical behavior as a regular benign hemangioma. These lesions have been subclassified morphologically into capillary, venous, or cavernous, depending on the type of the vessels. Capillary are the ones, with these small capillary-sized vascular spaces. Cavernous, as the example that we just saw, with these very dilated ectatic vascular channels, and then venous hemangiomas that are those hemangiomas that are lined with a muscular wall with different thickness. Now, these tend to have, as I mentioned, this circumscribed border and kind of this lobulated growth, and they are formed by these blunt, these vessels with blunt cytologic features. We don't see anything concerning in general. The issue is that sometimes, typically these lesions are located in the subcutaneous tissue. The issue is that when they're centered in the breast parenchyma, the edges may be more difficult to define, and they may have, this appearance that they're more infiltrative. However, when we look at, the type of the vessels that are usually rounded, no internastomosic pattern or something like that, and they're cytologically very blunt, these are all consistent with a hemangioma. Now, as I mentioned before, there is a subset, a small subset of hemangiomas that can sometimes have these atypical features, right? Sometimes a little bit of an infiltrated edge, or as in this case, a little bit of a more complex architecture, as you can see here, with this kind of papillary growth or a little bit of hyperchromasia and internastomosic pattern of the vessels, as you can see here. But again, in these lesions, if they lack all the other features that are diagnostic of a malignant lesion, then you can classify it as a hemangioma with atypia or a typical hemangioma, and they have a good prognosis, same as a regular hemangioma. Now, moving on to the other spectrum of the vascular lesion, this is a very young patient with a large palpable mass with no history of cancer, and you can appreciate here on core biopsy extensive involvement of the breast parenchyma by a vascular proliferation. While most of the lesion was composed of these dilated and internastomotic vessels, then you can see areas with solid growth, composed of a spindle cell, and then also areas with blood lakes, which are these areas with stromal hemorrhage, and on higher power, you can appreciate nuclear pleomorphism and even mitotic figures. And though in this context, this is characteristic of or diagnostic of a primary angiosarcoma. Now, in this case, we have a different age group. This was a 50-year-old female with skin thickening and discoloration of the breast. She had a history of ipsilateral breast cancer, status post-excision, and chemoradiation 14 years prior to presentation. And you can see in this slide that there's a neoplasm involving diffusely involving the dermis with no extension or no involvement of the epidermis. And on higher power, you can see that this is a poorly differentiated tumor composed of nests of spindle and epithelial cells. And given that this is so undifferentiated, you can do IHC, and this will definitely highlight the nature of the lesion. With we can see that this is a vascular lesion, given that it's ER positive, and we ruled out also carcinoma, given the history of the patient, that it's cytokeratin negative.
I bought more eggs yesterday. Did you use the new box?
And given that in this context, this will be obviously an angiosarcoma, and in the context of radiation, this will be a radiation-associated angiosarcoma. Now, in a similar, in a patient with a similar history, this is a 56-year-old who presented with, instead of a large lesion, this was a skin papilla in the breasts, and she had a history of ipsilateral breast cancer and also chemoradiation. Nothing was seen on imaging. And then a punch biopsy was performed, and we can see a vascular lesion mainly confined to the upper dermis. It's composed of these small irregular vessels. Some of them appear to be kind of infiltrating or dissecting the dermal collagen, and they have these funny shapes, right? This interanastomotic pattern. They might have, as in here, mild nuclear hyperchromasia, though this slide, I think it's very dark. And but there are no areas of solid growth, no necrosis, no significant mitosis, and so this is diagnostic of an atypical vascular lesion. Now, a word on atypia in vascular lesions, just because when I remember when I was a trainee that I got confused, when you say atypical vascular lesion and whether if it was just a specific entity or just a descriptive term. So atypical vascular lesion is just reserved for this specific clinical pathologic diagnosis, which is only the setting, of these these benign lesions in the post-radiation setting. If we have something that it's on biopsy that looks a little bit, it's a vascular lesion, but may show some atypical features, we can be more descriptive and call it atypical vascular proliferation or vascular lesion with cytologic atypia or an infiltrated pattern or something like that, depending on what we see, because atypical vascular lesion is just a very distinct, it's a specific diagnosis. Now, we'll review together the clinical presentation of AVL and angiosarcoma, and then we'll focus specifically first on AVL and secondary angiosarcoma, given some clinical overlap. So AVL and secondary angiosarcomas are associated with radiation therapy, as I mentioned before in the examples. In AVL, the latency is shorter, usually less than 5 years, whereas angiosarcomas appear 5 to 10 years after completion of radiation. There is a subset of secondary angiosarcomas that appear in patients with chronic lymphedema, but this is currently a smaller, more rare. AVLs are typically diagnosed in patients in their 50s, whereas angiosarcomas in older patients. Radiation-associated angiosarcomas are very, very rare. However, they are the most common sarcoma of the breast. AVLs are confined to the skin, whereas angiosarcomas are typically primarily localized in the skin, but they can show secondary extension into the chest wall or the breast parenchyma. And on physical exam, AVLs appear as these small pink papules, whereas angiosarcomas are usually clinically larger lesions. Some patients refer them as bruising, or they can have palpable masses. Now, primary angiosarcomas, these are sporadic tumors appear in a younger population. These tumors are mainly localized in the breast parenchyma and can show secondary involvement of the skin, and they are typically large lesions, like presenting usually as palpable masses. Now, with regards to prognosis, AVLs are benign lesions that may recur but have no metastatic potential and are usually treated with complete excisions just to rule out an angiosarcoma. In contrast, both primary and secondary angiosarcomas have a very poor prognosis, and these patients are usually treated with mastectomy, with a subset of them either going chemotherapy and or radiation therapy. Now we'll review the spectrum of post-radiation vascular lesions together. As I mentioned before, this is the clinical presentation of a typical vascular lesion. In this case, this patient has multiple of them, and you can see them as these small pink papules. On histology, these are typically well circumscribed lesions localized in the dermis, and they sometimes have been described to have like a wedge shape. They are composed of these dilated interanestomotic vessels that are lined by a single cell of endothelial, by a single layer of endothelial cells that can show some, as you can see, a little bit of atypical hyperchromasia, but there's typically no multilayering or solid growth, mitosis, or necrosis. As we've seen before, these atypical vascular lesions can sometimes have, these features that are a little bit more concerning, such as infiltration or dissection of the dermal collagen. But then when you look at the vessels, they are just lined by a single layer of endothelial cells with maybe myelotypia, but no significant nuclear pleomorphism. In contrast, radiation-associated angiosarcomas present as clinical larger lesions, and in this case, this is a patient presented with a recurrent tumor at the site of a prior mastectomy scar, and you can see compared to the AVL that this is obviously more concerning. This is the subsequent excision where you can see these two nodules, one of each appears ulcerated. And on low power, you can appreciate sort of this multinodular growth of the angiosarcoma, which is very typical of these tumors, and also see very clearly the blood lakes. The tumor is predominantly composed of these solid growth of spindle cells with atypical nuclei. They typically have this vesicular chromatin with prominent nucleoli, and here you can even see the mitotic figures. Focally, the tumor shows is clearly forming some vascular spaces, and which is sometimes, it's very easy. It's very common to see in these angiosarcomas where you can see like focal areas with vascular formation. Now, we also know that angiosarcomas can have epithelial morphology, and this can sometimes be a little bit tricky. Like as in this case, where you can see these angiosarcoma with epithelial morphology, and even like some foci that can resemble even like gland formation, if anything. So it's very important, to keep in mind the clinical history and also look at the morphology of the entire tumor to see if there are any clues that can raise the concern for angiosarcoma. So to summarize the morphologic features of AVL and angiosarcomas, AVLs are these fairly well circumscribed lesions confined to the dermis, whereas angiosarcomas are diffuse and multinodular and can show extension into the underlying subcutaneous tissue and the breast parenchyma. Blood lakes, endothelial multilayering, papillary endothelial hyperplasia, or areas of solid growth are only seen in angiosarcomas, but not in atypical vascular lesions, which, and same thing, cytologically, atypical vascular lesions can show mild nuclear atypia and rare mitosis, whereas angiosarcomas usually have like a more marked pleomorphism. Now, it's important to keep in mind that, there are some common features, such as the presence of anastomotic dilated vessels, dissection of the dermal collagen, and nuclear hyperchromasia. And that's why most, in general, typical vascular lesions are excised. Now, MYC amplification is regarded as the hallmark of radiation-associated angiosarcomas, and probably many people may use it, as a diagnostic tool to differentiate between AVLs and secondary angiosarcomas. And there are different studies that looked at MYC status by IHC and MYC amplification, by IHC and FISH in AVLs and angiosarcomas. And what they found was that approximately 50 to 100% of radiation-induced angiosarcomas are MYC amplified, whereas this is rarely seen in primary angiosarcomas, and most importantly, none of the atypical vascular lesions showed MYC expression or amplification. They also found excellent concordance between FISH and IHC, meaning that IHC is a good surrogate for MYC amplification. Now, MYC is amplified in the majority of radiation-associated angiosarcomas. However, there's this subset of tumors that are not amplified. However, these tumors appear to have similar clinical pathologic features compared to amplified tumors. However, there's this study from Brazil from 2015 where they found that MYC-amplified tumors tend to have worse prognosis. So a few years back, we looked at the role of MYC amplification in this subset of secondary angiosarcomas. And we did a study here at MSK where we have like 81 radiation-associated angiosarcomas with known MYC amplification status. And while we found no, as in the previous study, we found no difference in the clinical pathologic features of this tumor, we found that MYC amplification was associated with a worse prognosis. Now moving on to primary angiosarcomas. These, as mentioned before, occur in young patients presenting with a clinically large lesion. It's primarily localized in the breast. And what's important is that these lesions show heterogeneous morphology. Now, as we know, this is the grading system that probably everyone knows that was originally described in the early 80s by Donnell and Rosen. And what they did in that initial description was they divided 40 angiosarcomas into low, intermediate, and high grade. And they found that all the tumors, regardless of grade, involved the res parenchyma, feature internal in vascular channels, and had hyperchromatic endothelial cells. However, those tumors that had solid growth, numerous mitosis, blood leaks, and necrosis were put into the high-grade group. On the other end, we have these the low-grade angiosarcomas, were those that were mainly composed of these open vessels with very rare mitosis and minimal tufting. And the intermediate grade group were those tumors that could have some papillary areas or even some minimal growth or minimal solid growth. So this is these are examples of what would be classified into each group. For low grade angiosarcoma, we have these tumors with this open interanastomotic vascular spaces. In the intermediate grade group, we could have tumors that could have some endothelial tufting or papillary formations, and which would form these minimal solid areas. And then on the high grade group, clearly, solid growth, numerous mitosis, necrosis, and blood leaks. And initially, histologic grade was thought to have prognostic significance, with high grade tumors that we can see here having much worse prognosis compared to low or intermediate grade angiosarcomas. However, more recent data has shown that the prognosis is uniformly poor regardless of tumor grade. So a couple of years ago, we decided to look at the prognostic value of the histologic grade in a uniform cohort of patients here that were treated here at MSK. But first, we decided to revise the morphologic criteria of the grading system. And given that these three features, involving the res parenchyma, the internastomotic vessels, and the hyperchromasia was seen in any grade, because these are essentially they have to be present in angiosarcoma. We decided to simplify, right? Then we reviewed the part of the endothelial tufting and papillary formations. Now, the original study mentions that the distinction between tufting and early papillary formation was based on the number of cells and the size of the clusters. And we felt that this is a very subjective and kind of ambiguous criteria. It's very difficult, right, to reproduce these criteria. And so we took it out. And also because we saw the presence of this papillary growth in many tumors that look otherwise low grade. Now, moving on to blood lakes. This term was originally described as areas of hemorrhage often associated with necrosis. However, when we read most of these studies, on angiosarcoma, they use it for large collection of extravasated blood, of stromal hemorrhage. So given that, and given that also extravasated red blood cells, or these blood lakes, or huge accumulation of stromal hemorrhage, we can also see it in otherwise low-grade tumor. We also decided to take it from these grading criteria. And so we were left with 3 variables. And we defined cutoffs for each category for better reproducibility. And so solid foci, which could include either spindles or epithelial morphology, was absent in low-grade tumor, could comprise up to 10% of the tumor area in intermediate-grade tumors, and more than 10% in high-grade tumors. For mitosis, we defined different cutoffs per millimeter square, because instead of high-power fields, as this is the recommendation of the current WHO classification, we defined different cutoffs for each category, and necrosis could only be seen in high-grade tumors. And so these are examples of what we defined as low-grade and intermediate-grade angiosarcomas. Low-grade could feature different variably sized vessels. Some of them were tightly packed and some of them look back to back. And I think that sometimes on low power, those can look like even like areas of solid growth. On low grade, we will also see like these areas with kind of papillary formation or endothelial tufting, but also you can also see these areas of hemorrhage in otherwise low grade tumors. Now, intermediate grade tumors could feature areas with solid growth, comprising up to 10% of the tumor area. And also, you could see rare mitosis, which are typically seen in these more proliferative areas. And so we had a cohort of 49 patients that were all treated at escape. This group was, the median age at diagnosis was 42 years old, and none of them had a history of radiation either to the breast or the chest wall. This typically presented as a palpable mass, and we had a median follow-up of 33 months. And what we found was that histologic grade had a strong impact on survival. And looking at the Kaplan-Meier curves, we found that the curves for low and intermediate grade tumors were not dissimilar, so we decided to lump them together. And so we had this new two-tier grade system, and we also found that this was also predictive of outcome, with lower grade tumors showing better prognosis compared to high-grade angiosarcomas, with a 5-year overall survival for high-grade tumors being 38% compared to low-grade tumors being 74%. Now, we're going to be moving on to one more vascular lesion, and this is kind of maybe controversial because it's extremely rare. So we have angiomatosis, right? This is a very extremely rare lesion with only a few cases described in the literature. Angiomatosis have been described in young patients, but also in children. And what is distinctive and worrisome of this lesion is that they are usually large and they have an infiltrating pattern with intranastomosing vessels. However, these vessels do not involve the intralobular stroma, meaning that they don't disrupt the lobular unit and they don't show cytologic atypia. They are typically treated with mastectomy, given that they are these large lesions. They may recur but have no metastatic potential. So as I mentioned before, these are usually very large lesions that show diffuse involvement of the breast parenchyma by these irregularly shaped intranastomosing vessels, as you can see here. They can show infiltration into the adipose tissue. And so, of course, these are very, very concerning features for angiosarcoma. However, when we compare them, we can see that what has been described is that angiomatosis, the vessels in angiomatosis do not involve the lobular unit, so you can see the vessels going around them, as opposed to angiosarcomas, where they dissect the terminal ductal lobular units. And also in angiomatosis, we have no cytologic atypia, compared to angiosarcoma, where we can see these open vessels, but when we look at the nuclei, they're clearly more atypical. Now, Ki67 has been reported to be usually less than 5% in angiomatosis, and we'll review the role of Ki67 in this lesion in the next slides. So the role, IHC in vascular lesions can only be used in combination with morphology and clinical presentation, and by itself is not a diagnostic tool. So there are a few markers that we can use that can help us distinguish between benign and malignant lesions, such as Ki67, SMA, ERK, and CD31, and MYC, and we'll expand on this in the following slides. And of course, we can also use IHC to distinguish between angiosarcoma and other types of malignancies. Now, Ki67 can help in the classification of vascular lesions, benign versus malignant. However, there are no guidelines regarding cutoff or interpretation of this marker in vascular lesions. In general, it has been reported that benign lesions have a score of less than 5%. The group at Cornell examined the value of Ki67 to distinguish between malignant and benign vascular lesions in a study that they published in 2007, and they had 34 vascular lesions of the breast. And what they did was they counted the number of positive Ki67 cells using a denominator of 1,000 lesional cells. And what they found is that using a cutoff of 150, they had 100% sensitivity and 91% specificity to distinguish between the two. Meaning, although this is not completely equivalent, this would mean that a Ki-67 score of 15% could potentially be used as a cutoff to distinguish between benign and malignant. However, they noted that there were higher, the index was higher in areas obviously adjacent to site changes and thrombi, and this is also, in areas of necrosis, which is, this not only applies to vascular lesion, but in assessing Ki-67 in any other tumor. But this is I think that this would be an example in which I think it would be helpful. So on one side, we have on the left side, we have the angiosarcoma, low-grade angiosarcoma, and you can see that most of the tumor cells are Ki-67 positive, whereas, in this hemangioma, we can see rare expression by the lesional cells. Now, SMA, smooth muscle actin, can be helpful to highlight pericytes surrounding, vessels in benign lesions. However, it should be noted that SMA has also been reported, like aberrant expression in some angiosarcomas. So interpretation should be also be in conjunction with morphology. Now, ERG and CD31 by themselves, they're not going to distinguish between benign and malignant, but they can help highlight the pattern, especially if it's a very infiltrative lesion or a very inconspicuous lesion, then you can help highlight the pattern of the vascular lesion. And of course, as mentioned before, they can use to confirm endothelial differentiation if there are other tumors in the differential. Now, a few differential diagnoses, for angiosarcoma. I'm going to go briefly because I'm not sure if I have enough time, but so this is a 40-year-old woman with a palpable mass, and we can see here a vascular proliferation, mainly involving the adipose tissue. On higher power, you can see these small vessels with a small fibrin thrombi. These are characteristic of an angiolipoma. Now, the proportion, of course, of vessels and adipose tissue in this lesion can vary, right? And when there's more than 50%, apparently more than 50% vascular component, then these have been classified as cellular angiolipomas. And the issue with this lesion is that the fat component can be very scarce and difficult to identify, and so they may raise concern for an angiosarcoma. However, this, when you look at higher power, maybe lower power, you can see kind of this lobular configuration, but on higher power, you can see the characteristic fibrin thrombi, and also there's no nuclear atypia on these lesions. Now, another lesion in the differential for angiosarcoma. Here we have a 73-year-old man with a rapidly enlarging 5-centimeter axillary mass. He had a history of breast cancer, but he did not receive radiation. So we can see here this vascular lesion with a very complex architecture. The patient underwent an excision, which showed the lesion with this papillary and complex intranastomosing pattern, which is concerning. But however, there was no cytologic atypia. And when you look at the edges of the lesion, you can see that it is very well circumscribed, and there are areas of old and recent hemorrhage. We can explain the recent growth. And therefore, this is diagnosis of papillary endothelial hyperplasia. Now, this lesion, also known as Mason lesion or Mason tumor, have been described as reactive endothelial hyperplasia that occur in hemangiomas that have undergone thrombosis, and the endothelial hyperplasia that happens secondary to the thrombosis can have like a very complex and concerning pattern. However, these are usually well circumscribed and there's no atypia. Now, in the other differential of angiosarcoma, we have this 74-year-old woman with a palpable mass. No history of breast cancer or other malignancies, and you can see here in the deep dermis and also extending into the breast parenchyma, this neoplasm this neoplasm formed by these very atypical cells. Some of them tend to have like these spaces, and it's definitely malignant with some areas with some solid growth, and so obviously this kind of morphology raises concern for a vascular lesion, right? Because of the pattern of the architecture. And so IHC was done, and you can see that this is clearly cytokeratin positive, whereas the vascular markers were negative. And this is something also to keep in the differential. Metaplastic carcinoma can sometimes mimic angiosarcoma. Now, moving on quickly to a few challenging cases. Some of these were seen in consultation, and Dr. Brodzic kindly shared them with me. So first one is a 74-year-old female with a 1.3 centimeter breast mass detected on screening mammogram. She had no history of breast cancer. On a low power, you can even see that it is a very complex vascular lesion, right? Like very busy with areas of papillary growth, there are areas of hemorrhage, maybe some fibrin deposition. And on higher power, you can better appreciate sort of this interanastomotic pattern of this lesion with some papillary formation. Maybe the cells overall look pretty bland. However, there may be some nuclear hyperchromasia or maybe some nuclear enlargement. The outside pathologists did Ki67, and these the Ki67 stains show higher, like a higher score on the areas with fibrin deposition, whereas the areas away from that, you can see, as in the slide, were lower, approximately 5%. And so in this core biopsy, given this very suspicious or very concerning morphology, this was diagnosed as an atypical vascular proliferation. And then it was mentioned that the differential diagnosis could range, from a benign hemangioma with papillary endothelial hyperplasia to an angiosarcoma. And so excision was recommended, and then the patient came for the excision here, and you can see that there's this vascular lesion that has kind of a nodular pattern on low power. And it's, yes, and lobular pattern with this kind of circumscribed edges, but you can see that it has a very complex architecture with these interanestomosis vessels. There's a lot of fibrin deposition. However, you can see that there's no, atypia on the endothelial cells. Again, the Ki67 was repeated, showing the same kind of pattern with, a higher Ki67 score in the areas with fibrin deposition. And so this was diagnosed as a hemangioma with atypia and likely represents a hemangioma that underwent thrombosis. Now, this is another case. This was a 43-year-old, a core biopsy in a 43-year-old with calcifications detected on screening mammogram, and the outside pathologist was wondering if this could be a low-grade angiosarcoma versus a benign lesion. Now, calcifications were found somewhere else in benign breast tissue. And then what you can see here is that there's this vascular proliferation that's sort of like kind of infiltrating the breast parenchyma and also going into the fat. However, when you look on higher power, you can see that this is composed of relatively bland, open and small vessels. And so this was diagnosed as a benign breast parenchyma, as a hemangioma, and the calcifications were seen in another part of the core. Now, moving on, this is an 8-year-old female with a left breast mass. She had a history of radiation in the contralateral breast, and you can see here a very cellular lesion. It appears to have kind of a circumscribed edge. And you can see in the lesion, very cellular areas that mix with fat. On higher power, you can appreciate that there are actually small vessels, most of them with fibrin thrombi. And an Eric stain will highlight that this is an endothelial proliferation, and Ki67 was very low. And so the morphologic feature would suggest that this is a cellular angiolipoma. However, the outside pathologist also did a mixed stain, which shows, some positivity in the tumors, the lesional cells. And the truth is that we don't know what MYC expression means in these benign lesions because we never do it. So the diagnosis is still based on morphology, and this is cellular angiolipoma with a comment saying that MYC amplification has a certain significance in this lesion. And last case here, we have a 69-year-old female with a breast skin nodule. No history was provided, so you can see here neoplasm in the dermis, composed of this solid growth of highly pleomorphic cells, poorly differentiated tumor, but once IHC was done, it showed that this was a vascular tumor, an angiosarcoma, and MYC was also done and showed positivity, and later it was found that this patient also had a history of radiation in the same breast. So these are all things to keep in the differential diagnosis. Now, moving on quickly to the management of vascular lesions of the breast diagnosed on core needle biopsy, we're just going to review the data on some recent studies. Because in the past, all benign vascular lesions diagnosed on core needle biopsy would undergo excision regardless, to rule out a low-grade angiosarcoma. However, more recent studies have suggested that not all vascular lesions diagnosed on cord needle biopsies should be excised. And so this first study, they had 27 lesions diagnosed on cord needle biopsy. They classified it as lesions without atypia and lesions with atypia, and 16 of these 27 lesions were excised, and only one of them was upgraded. And this one was a 50-year-old lady with an incidental mass on MRI, and on cord biopsy was called as a vascular lesion with atypia. A second study that was done here at MSK had 84 cases. And to summarize it, essentially all cases that were called benign on cord needle biopsy, none of them were upgraded. Similarly, all the cases that were called vascular lesion with atypia, none of them were upgraded on excision. Now, the last study that had 117 cases, similarly to the results of seen on MSK, none of the cases that were called benign show an upgrade on excision, and similarly, none of the cases that were called atypical hemangioma on cord biopsy were upgraded to angiosarcoma. So to summarize, vascular lesions without atypia on cord needle biopsy, all these studies have shown that none of them were upgraded to angiosarcoma on excision, and none show clinical or imaging progression. So for those lesions that are morphologically benign on cord needle biopsy, but we don't see any atypical features, these patients can go conservative management. Now, in cases where we see on cord needle biopsy the atypical features, as mentioned before, focally infiltrating margins or some nuclear hyperchromasia, or like this funny pattern of interanastomotic vessels, then we have to take into account also the clinical presentation. However, in most cases, excision will still be recommended to rule out an angiosarcoma. And then obviously malignant lesions, these patients are treated with excision, and then a subset of them will undergo adjuvant therapy. Now, to conclude the talk, as we mentioned, most vascular lesions of the breast are incidental findings on cord needle biopsy. Benign lesions diagnosed on cord needle biopsies may be spared excision if they are radiologic pathologic concordant. That's a very important thing also to take into account. Vascular lesions with atypia or atypical vascular proliferations, we may need to do an excision for a definitive diagnosis. Primary angiosarcomas have heterogeneous morphology, but we know that these tumors present in young patients, presenting usually as large lesions, and histologic grading should be reserved for excisions unless it's clearly high grade on biopsy. Now, we saw atypical vascular lesions and radiation-associated angiosarcomas can show significant morphologic overlap on biopsy, and therefore it's important to take into account the clinical presentation. Excision may be necessary for final classification of this lesion, and radiation-associated angiosarcomas is amplified in the majority of the cases, and given that AVLs have never been described to be amplified, these can be used as diagnostic with appropriate morphology. And now I want to thank you all for your attention, and I'm happy to take any questions.
Thank you, Dr. Kuba, for your very informative talk. So if anyone's got any questions, please feel free to ask now. If not, I'll start with one myself. So you mentioned earlier on that for atypical vascular lesions, this is essentially a clinical pathologic diagnosis. So do you think we can actually make this diagnosis based on pathology alone, or is this going to be one of those cases where, like inflammatory breast cancer, where we kind of say, oh, we have to correlate with the clinical presentation?
Yes, I know what you mean. So yes, so if we have it in an excision, it's it's easier, right? On cord biopsy, we're just gonna, some people may do it. Some people may call it actually atypical vascular lesion on cord biopsy based because they already know the clinical presentation. But yeah, no, we can do the diagnosis only based on pathology, as long as we know as long as we can see the entire lesion and we know that this is a patient that received radiation therapy, if it makes any sense.
Right. Okay.
Yeah, it's not like inflammatory cancer, because usually we don't diagnose even here inflammatory cancer, in a pathology report. That's like just a clinical correlation.
I see. So do you ever diagnose atypical vascular lesion on the cord biopsy, or do you always wait for the excision?
that is a very interesting thing. I think that some people, especially like the most, experienced soft tissue pathologists, may do it on core biopsy. For example, like the patient that I showed you, right, that had like multiple vascular lesions with multiple papules. This is a patient that had recurrent vascular lesions over and over and over. And they wouldn't be excising all of those, little papules that she had. And so given in the context of that clinical presentation, they may just diagnose the corneal biopsy and not excise it. But you have to know very well what the clinical presentation is.
I see. I have a few questions in the chat room. So, is there utility in separating atypical vascular lesion into lymphatic versus blood vessels subtypes?
Oh, that was the initial, yeah. We don't do it here. I mean, like we don't separate them. I know that, yeah, this was in the initials in one of the studies, but Sharon Weiss, I think that they classified into both, but we don't classify. We currently don't classify it, and to be honest, I don't know if there's any significance in terms of prognosis.
Right.
It's more like a morphologic classification.
I see. Okay. And another question from the audience: do you see atypical vascular lesion in association with angiosarcoma?
That's a very interesting question. So it's well, these are lesions that appear in the same patient population, right? Patients with, right, that are being exposed to radiation. Yes, I think it's very common to, not common. It wouldn't be unusual to see atypical vascular lesions in a patient with that has also angiosarcoma, right? Because they are the same. They both have the same risk. I mean, not the same risk, but they're both patients at risk. The issue that sometimes, for example, it's not uncommon for an angiosarcoma to have, areas resembling AVLs at the edges of the lesion, right?
Mm-hmm.
And that's why sometimes if we think, yes, that's why, if the lesion is very large and we see something that looks like an AVL, we need to, the clinician has to do the correlation to see if this is actually a well-sampled lesion, right? Because it could be the edge of an angiosarcoma, and that's why probably most AVLs are excised. Yeah. The other question that I think comes with that is whether AVLs can progress to angiosarcomas, because that's also something that sometimes, there are reports of AVL, of angiosarcomas arising in the same area where there was an AVL before, but it's very difficult to prove that, because it's not like an in situ lesion that then, infiltrates. It's very difficult to prove that they are chronically related, because it hasn't never been proved, especially because AVLs are paucicellular in general.
Right.
And yeah. So sorry, to answer the question, yes, it's not uncommon to see both lesions in a patient, or CAVL in a patient that also has an angiosarcoma. However, the relationship between these two is difficult to understand.
I see. Okay. And I have another question myself. You mentioned earlier on that, sorry, kind of towards your final slides, when you're talking about angiosarcoma, that you do kind of histologic grading. So is that kind of standard practice at MSK?
Yes. Well, yes. We mentioned, yeah, because I think that, well, I don't know exactly what everyone does, but yes, we do mention the histologic grade. We mentioned it. Yes, we mentioned like morphologically, whatever grade we see an excision. I mean, on core biopsies, it's very difficult unless it's high grade, obviously, right? Necrosis, necropomorphism, all that stuff. But yes, on excisions, we grade the angiosarcomas.
I see. And so as far as you know, does that actually...
For primary, sorry, yes, for primary angiosarcoma.
Sorry. So as far as you know, do you know if that actually has an impact on patient management? Because I know you mentioned that like the prognosis is different.
Yeah, so far, no, we haven't seen anything. Also, this is like a recent study and there's no validation of this thing. No, I mean, it's obviously going to be very difficult, but so far, I don't think that we haven't seen any difference in patient treatment in these two, in each category. yes, but we just saw that regardless, even if the patient had the same treatment, some of them would behave better.
All right, I see.
But not so poor.
I have another question coming
Yeah.
in. Can we rely on the presence of Can we rely on the presence of nodal involvement by vascular tumor to distinguish cases of angiosarcoma that looks like hemangioma and render the diagnosis of angiosarcoma? So I guess if you have vascular tumor in the node, does that automatically make it angiosarcoma?
So that's funny because you can have actually hemangiomas in the lymph node, right?
Right.
So, so it's all based on morphology. I mean, usually angiosarcomas do not go to the lymph nodes, but yes, I mean, it depends all on the morphology in this case. I mean, just because you see a vascular lesion in the lymph node doesn't mean that it's a metastasis.
I see. Okay.
And so, yes, you have to compare it with the primary and also the morphology, whatever you see in the lymph node.
And then just one final question. If you're not able to get clinical history, is it okay not to recommend excision for bland benign vascular lesions on core biopsy? Or do you just keep the diagnosis descriptive and leave the management to the clinician?
That's a very good question, because this is like probably something that a lot of people in communities, pathologists in the community setting may encounter. So so I think that if you see that there's nothing, I mean, if you don't have any clinical history, that's like terrifying. But if you don't, I mean, if you see something that's otherwise very, very blunt, right? Like if you see a perilobular hemangioma, you would never recommend excision for a perilobular hemangioma, right? That's something that probably we can just we can all agree probably. But the issue is when you have like this hemangioma, right? And I think that if you're in a vacuum, you can just describe it and say findings are compatible with whatever with hemangioma in this, in this material, and then the clinician or the surgeon or whoever may do whatever. I mean, they have to correlate with whatever they are seeing, in the imaging studies or on the clinical presentation with the patient, because you can do as much as you want. But I think that so I think that if it's benign, you can just describe it and say, compatible with whatever you think it's, hemangioma or whatever. Papillary endothelial hyperplasia, focus of papillary endothelial hyperplasia, but that's more tricky. But I think that yes, if it's benign completely, if you don't see anything suspicious, I think it's not incorrect or inappropriate to just say suggestive of a hemangioma, whatever it is, and then they can do whatever they want.
Right. Okay. So if there are no further questions, I'd like to take this opportunity to thank Dr. Kuba for her very interesting presentation, and it certainly has generated a lot of discussion. Thank you so much for being with us. So I'm going to move on to the next portion of the meeting here. So we're going to go to Dr. Zora Islami from Scarborough General Hospital for her case presentation.
Okay, my talk will be very related to Dr. Kuba's talk, and maybe I repeat some of the stuff which she mentioned very nicely. I'm presenting some of the cases in our department in SHN regarding breast vascular lesion. As she said, they are benign, atypical, and malignant. And when it comes to the breast biopsy, all of us have experienced how much it is difficult, especially in the last 2-1 atypical and well-differentiated angiosarcoma. I'm presenting, the first case which I'm presenting is a 57 years old female. She had on the mammogram, she had a BIRAT4 with some calcification. The diagnosis was fibrocystic disease and then benign hemangioma. As was mentioned, in benign hemangioma, it was mostly interlobular and prelobular pattern, which I think Dr. Kuba's talked about it enough. And then the second case which I had, it was a 60 years old lady which had a surgery in 1999 with axillary node dissection for an invasive ductal carcinoma. She had adjuvant radiation with endocrine treatment, and then recently she had a new lesion. Plus she had bone metastasis, and her tumor nodules on the breast skin was painless, and it was she was losing lots of blood, which sometimes she need transfusion. Therefore, the surgeon didn't do the biopsy. She did a straightforward simple mastectomy, and this is what we had it. As you can see, the dilated vessels, and there was some anastomosis and some atypia. And as they said, that there are two subtypes, lymphatic and vascular subtype, which Dr. Kuba said that it is not significant for the clinical and prognostic. Anyhow, but the only things which I find out because normally CMYC shouldn't be positive in atypical vascular lesion, but there are reports that said that there may be patchy positive of CMYC expression in AVL. And that makes so stressful as when you have, especially in biopsy. The last case which I present was 86 years old patient. She had a modified radical mastectomy on 2016. Diagnosis was invasive pleomorphic lobular carcinoma. One of her 13 lymph nodes was positive, and she was PT2N1A. She was ER positive, HER2 negative. She didn't have adjuvant systemic chemo, but she did have radiation to her right chest wall and axilla. And then recently she noticed a change in her right chest wall with 3 areas of discoloration. And when they were doing examination, they find out it is look like bruising, and some area was very firm, and there was multiple nodules, which was from 3 to 5 centimeter. This is the biopsy from one of the nodules, and as you can see, there is a haphazard pattern of the infiltrating spindle cell type cells, which was, there are pleomorphism, there are hyperchromatic, and we did CD34, which was completely and extensive positive, and CMYC also showed that diffuse nuclear positivity, which called angiosarcoma post-radiation. And this one was mentioned before, which there are a histologic pattern of the angiosarcoma. Now they are doing the low grade and high grade. Anyhow, but because of this, I decided to do a retrospective study and see how many AVL we had during 10 years of our, breast, in our breast department. And I find just 4 cases, which was diagnosed in SHN, and they called AVL. All of them were female, aged from 43 to 71, and they had previous history of radiation therapy or mastectomy. From these 4 AVL, 2 of them after a while, they had a diagnosis of angiosarcoma. I don't know, because now as Dr. Kuba mentioned it, this may be they had AVL and angiosarcoma before, or this is a transformation of the AVL to the angiosarcoma. And whatever from this study, what we put as a notice and a take-home message is that we could not identify an unequivocal clinical or histology criteria that allow us to separate between AVL and well-differentiated AS, especially when it comes to breast biopsies, core biopsies, which is very small. And histology features and immunoreaction to c-MYC should help us, but as you see, there are reports which c-MYC may be patchy positivity in the AVL. Then we need to be aware of the overlap between these two entities, and all patients who receive a diagnosis of AVL should undergo complete excision with close clinical follow-up and biopsy of any new lesion. And thank you. That was my presentation.
Thank you, Dr. Salami. It's very interesting following on from our lecture just now. Does anyone have any questions that they'd like to ask?
I have a question for Zori. Do you know by any chance if one of the cases that so-called recurred as angiosarc was one of those that was MYC positive?
No, actually, they were MYC negative. And for us, for example, even this AVL, which we had it in excision, we sent it actually to Sunnybrook and it was MYC negative. But the angiosarcoma we sent it was MYC positive. But the from these four, I don't know. After that, we had the patient has a second lesion after a while, because this study was in from 2003 to 2023, which we look at it. They had after that MYC positive and angiosarcoma, two of these four. But I don't know, as Dr. Kuba said, that maybe these are two different lesions, or maybe this is the transformation from AVL to angiosarcoma.
Well, thank you, Dr. Salami. So if there are no further questions, we'll move on to the next presentation from Dr. Harpreet Ray.
So my name is Harpreet Rai. I'm one of the clinical fellows at Sunnybrook Health Sciences Department. So the case I'm presenting is, this is the case that we got as a part of our biomarker testing, and we received one block. And the history provided to us is the 44-year-old female with the right breast mass and core biopsy was done. And this is the lesion this is what we received on the block and the H&E that we received from biomarker testing. So what we see here at the low power, we have two core biopsies. And the intermediate power, what we see is a cribiform pattern of neoplasm with the dense hyalinized stroma. This is the larger, this is the magnification of the same lesion. As I have shown here, one of the lesions, I increased it in size just to show like how it looks like. So what we see is basically we have this cribiform pattern of the tumor architecture. The cells, they have eosinophilic cytoplasm, abundant eosinophilic cytoplasm. Some of it looks foamy. And the nuclear grade was low to intermediate. And there was abundant of this eosinophilic or amphiphilic granular cytoplasm, like granular substance in it. And there was no mitosis. So anybody has the guess on this? I will go back just to show how it looks. Okay, I got two answers. So continuing with the IHC, what we did the GATA3, which showed that this is the breast. And then these are all actually good differentials that I'm getting for this lesion. Because it was a cribiform pattern, we wanted to make sure that this is not, this in situ or an invasive component. So the triple immunostain that we did, which is SMM, P63, and low molecular weight keratin, it showed that there was no myoepithelial cells. And this marker was triple negative. So HER2 was low, it was about 8%. So not completely triple negative, but PR was negative and HER2 was negative in this case. And based on the answers that I got, we did one, so all the other differentials, the other one differential we had was the secretory carcinoma. So we did the PENTRAC, which was positive in this tumor. So this is the case of invasive secretory carcinoma, which came for biomarkers to us. So I thought it would be interesting to share because this is a very rare entity. It's seen only in less than 0.05% of the invasive carcinoma, and most common age group is 4 to 7 decade. Even though this carcinoma initially was discovered in children, it's in the pediatric age group that it was initially found. But then later on in adults, it was found as well. So its name was changed to secretory carcinoma. Clinically, these tumors, they are very slow growing, firm, painless, mobile mass. They may or may not present with nipple discharge based on where they are present in the breast. And they have a very indolent and excellent prognosis. So based on like the clinical presentation, so they could be near the nipple or they could be in one of the quadrants. Most commonly is the upper outer quadrant. And they are solitary, well circumscribed and grayish white in color. And microscopy, as I showed you before, these tumor cells, they are polygonal tumor cells with eosinophilic granular or vacuolated cytoplasm, and they have low nuclear grade, round to oval nuclei, which are arranged in microcystic or honeycomb pattern. And the architecture could be solid, tubular, or papillary growth patterns. And then they have intracytoplasmic or extracellular eosinophilic or amphophilic secretions, which we saw in our lesion as well. And these secretions, they are PAS, mucicarmine, or alcyon blue positive. And they're usually low grade, and they may or may not have an in situ component. If they do have an in situ component, then it's usually a cribiform or a solid pattern of carcinoma in situ. And it has been described in WHO that the stroma is very sclerotic. Ancillary testing, as I said, and special stains we do is PAS, mucicarmine, and or alcyon blue. And these tumors, they are strongly show diffuse pattern positivity for hemoglobin, SOX10, S1 and MUC4. GATA3 may or may not be positive in these tumors all the time. And they also express basal markers, CK5-6. And as I said, GATA3, CK8-18, and CD117 may or may not be positive. The important thing about this tumor is that the biomarker profile, they could be triple negative, or they may show weak ER positivity, which is not uncommon in this tumor. And they're associated with a very pathognomic translocation, which is seen in 95% of the patients, which is translocation 1215, which makes a fusion gene product, ETV6 and TRK3 with the translocation. And they, as the staging is concerned, they are usually PT1 or PT2, and axillary or distant metastasis in them is rare. So as based on the answers that I got, so the differential diagnosis for this tumor is it could be invasive carcinoma with apocrine differentiation, especially when if it's a solid pattern, and we see these eosinophilic cytoplasm and these but in apocrine, we don't see the vacuolated cytoplasm. It's more of an eosinophilic cytoplasm. And apocrine in 50% of the cases are HER2 positive as compared to these tumors, which are either triple negative or they have low ER expression, but HER2 is negative in them. As somebody mentioned, ethnic cell carcinoma in the diagnosis, yes, it is also one of the differential diagnoses. However, it lacks the translocation. And actinic cell, as same as in salivary gland counterpart, it will express such other components like lysoenzyme or chymotrypsin. Invasive cribiform carcinoma that can also present like this. However, in that case, the cytoplasm is again not foamy or vacuolated, and most of these cribiform patterns, they are low grade and they're hormone positive. And then also somebody mentioned cystic hypersecretory carcinoma in situ. Yes, that is also one of the differentials that we thought about it. They are usually there's a grossly evident cystic space, and which is filled with eosinophilic material in case of cystic hypersecretory carcinoma. And when you do the triple immunostain or you do the smooth muscle marker or P63, it will show intact myoepithelial cell layer. And then the nuclei, in case of cystic hypersecretory carcinoma, they are more pleomorphic and the cytoplasm is scant as compared to secretory, where it's more eosinophilic and vacuolated cytoplasm. So according to WHO, there are essential and desirable diagnostic criteria for secretory carcinoma. The essential is that they have a characteristic morphology, that is that eosinophilic vacuolated cytoplasm, and then the presence of these extracellular and intracellular eosinophilic or amphophilic secretions, and the immunophenotype as they have described. And they are usually triple negative or weakly ER or PR positive, as I said, as far as biomarker profile is concerned. And we can do either a FISH or we can do next generation sequencing to look for the fusion or the ETV6 rearrangement, or we can do also IHC now, which shows pan-track positivity. Thank you. These are my references.
Thank you so much. This is certainly super rare, and I have to say I've not diagnosed this myself before. Does anyone have any questions about this case?
I would like to ask Harpreet for her opinion. Why is it important at this point of core biopsy to render a specific diagnosis and differentiate it from just the run-of-the-mill invasive breast carcinoma?
So one is the treatment component of this this tumor. Like their treatment is the same as far as is concerned, but they have very excellent prognosis. So that's why we need to be aware of that as compared to the other invasive ductal carcinoma, which is run of the mill.
Yeah, it's really important to make sure that we don't miss it, because we don't want these patients to receive neoadjuvant chemotherapy.
Yes.
So it is one of those so-called triple negative tumors that are more indolent. Yeah.
I have a question from the chat room. Can the diagnosis be made without translocation? For instance, what do you do with the remaining 5% that doesn't have that translocation?
So according to WHO, the translocation, they have put it in a desirable category. So it's more, so my understanding based on reading that was, it's based on more on the morphology and the immunoprofile. And this translocation actually is only seen in 95% of the tumors based on the literature search I looked at.
And also, Harpreet, I think that you mentioned the full immunoprofile, and it included S100, right?
Yes.
Yeah, so people who don't have NTRK, but they do have a higher suspicion, they can try S100 as well, and can refer it to a lab that has NTRK.
Well, thank you very much. We'll move on to the next presentation. That's
Thank
from
you.
Dr. Birknick, and it's from Mount Sinai Hospital. So please go ahead.
So mine is not so much about diagnostic dilemma, more of a kind of an interesting observation, as now we're seeing more and more breast post treatments, and with the new agents coming on board, we're kind of going to notice some more differences or possibly related to the therapy. So the case of a 61-year-old woman who had a palpable breast mass. It was originally suspected mastitis. It was at the central breast, 7 centimeters from the nipple, almost 4 centimeters inside size, and it was had mixed solid and cystic features, and there was a prominent axillary lymph node on imaging. Initial biopsy was called chronic mastitis. There was a repeat biopsy which showed invasive carcinoma. It was triple negative, and then the FNA of the biopsy was also negative. She was enrolled in the Keynote 522 trial, and based on the clinical note, she was in the arm that received pembrolizumab plus chemo. So pembro is the checkpoint inhibitor, so immunotherapy. Post-treatment MRI said there was a complete response, no prominent lymph nodes. There was really nothing really enhancing in the breast. So patient underwent a lumpectomy and sentinel node biopsy. And this is the low power field of the tumor bed. We see quite a dense inflammatory response, and there is this biopsy site reaction nearby. And when you go to the higher power, it's really dense chronic inflammation, predominantly macrophages with hemosiderin. No evidence of residual disease or even in situ disease in the background. You can see some of the benign breast that's remnants of it, and they look fairly sclerotic. And then moving on through the rest of her tumor bed, it's pretty much more of the same, just a lot of hemosiderin-laden macrophages. And what was really eye-catching is wherever you look for the normal breast or TDLUs, they all look fairly sclerosed or sclerotic. And even in the areas where there wasn't much of the tumor bed, all the TDLUs look sclerotic. So moving away from the area that didn't have any tumor bed or any disease, this was the lower power field. And, usually post-neoadjuvant chemo, we do see breast that might look more like post-menopausal, especially in a younger patient. So they may look more attenuated, but every single TDLU that I could find looked completely sclerosed, very fibrotic through the middle. It looked very distinct. Even in here, there was a little bit of collagenous ferrulosis. So I couldn't find if these were just incidental finding versus if there's any histologic changes related to pembro therapy. There was really nothing much in the literature. I know for the patient that do develop side effects from these treatments, like colitis, our GI group does say that they do notice that colitis look very distinct from IBD, like colitis. It doesn't have the typical, like the classic features. But so far in breast, I couldn't really find anything that's been reported. We did have another case of similar patient that was on pembro, and the breast in the background did look fairly sclerotic. But again, I don't know if that would be just an incidental finding versus something that was really related to the treatment. But as we see more and more of these cases, maybe these would be more classic findings or not. I just thought it was interesting to share.
Oh, thank you so much. This is a really fascinating observation. I wonder if anyone else has had experience, if they've come across cases that's been treated with immunotherapy, and if they've seen very similar appearance. Does anyone have anything to say about this?
I have not seen that, but maybe I just didn't pay attention. But Marilyn, we do have a lot of patients that get immunotherapy in the neoadjuvant setting, and I will keep my eye on it. And maybe worth looking back. Yeah. That's great observation.
Well, I think one interesting thing that I'd be interested in finding out in terms of what you do is if we do have cases like this where you have very diffuse changes across the board and you can't find residual tumor, and how like in cases where you think there may be complete response, you want to make sure that you've got the correct diagnosis. So like in my practice, I tend to do like deeper some areas where I can see treatment changes. In cases like this, where you have diffuse sclerosis, I mean, without those, I guess, hemosiderin, like where would you go? I mean,
right. I mean, I did do quite a few pan-CKs, and because it's so dense with hemosiderin, I had to select the red chromogen just to kind of see if there's any tumor cells hiding in the background. But yeah, there was really nothing in the background to find. And so far, a few of these cases that did come aboard, a lot of them did have complete response, which was also very interesting. So I wonder if we'll see at the end of the trial how the pathologies compare. But it was really very striking because this was a sizable tumor before treatment, and few other cases that we did have were also sizable tumors that almost completely melted away with therapy.
All right. So thank you. So if there are no further questions, we'll move on to our next presentation from Dr. Dina Bowles from Oak Valley Health.
Okay, so hi everybody, my name is Dina. I work at Markham Stouffville Hospital, and I'll be presenting, I have two cases, but I'll present the first case first, and then we'll go for the next one if we have time. So the history, she's a 68-year-old female patient that came with a palpable breast lump. Mammography and ultrasound showed a regular mass 2.4 centimeter by RAD5 in the right breast. Breast biopsy was performed. No family history of breast cancer was known. And for the past medical history, the patient didn't have any history of cancer. There was ovarian cystectomy done before. We couldn't find the path report for that, but it was benign based on the patient, tubal ligation, perianal abscess, nothing of significance in this case. So this was the core biopsy. We got 2 core biopsies, but I'm showing this one because for us it was the most interesting. So I'm going to go at higher power. I'll focus on this area where there are some rounded, like glandular structures, and then this sclerotic/hyalinized area with a lot of infiltrative stuff, and then this crushed area at the edge. So first, these areas you can see, like it's a bit of medium power, but you can see how the glands here, they're kind of rounded, maybe lined by single layer of atypical cells. And here also it's exactly the same. Going higher power, these round glands that are lined by single layer of atypical cells. And the look of it, it gave us the, like, could this represent atypical microglandular adenosis, which is usually very important. At least for me, I learned, like, when I'm thinking about cases like this, and looking at it, I have to think about it because these are usually the myopathial cells are negative rounded and triple negative, just so we don't mistake this for invasive carcinoma. So the look of these glands raised the possibility that this could be atypical MGA. Going at another view, still we see these glands that are very rounded, like with lined by single layer of atypical cells. So this area we thought could this be atypical MGA. So now is there invasive carcinoma? So now going to this area where we see these infiltrative are these like glands that are infiltrative in hyalinized sclerotic stroma. Also here, this area, and this is going towards this crushed area. Higher power view, we see it's more or less infiltrative within hyalinized sclerotic stroma in the background, which we thought, like, you know, this together with the other core, I have to say, especially with the background of atypical MGA, we had to make sure that there is invasion, but overall, we were kind of convinced that there is enough to call that there is invasive carcinoma in this area. Going at this at the edge, to be honest, it's extremely crushed. Like we couldn't see anything. There is like we couldn't make any details in this area. I tried to take a 40x bar view. It's just like it's extremely crushed. There is like we couldn't make anything. It's just crushed tumor cells. So because we thought that there could be a typical MGA, we did multiple immunos. Of course, the first one we do is ATH. ATH is a cocktail, which is CK7, the red chromogen, CK5, the brown, and then the P63 is the nuclear brown staining. So here we see this area, which looks like the atypical MGA. It has the red chromogen, CK7 positive. Some areas here are kind of lost. It could be from the crushing artifact. It could be not staining. Here, some of the areas here, all I have to mention that all over it was P63 and SMM dead negative. Some areas here had CK5 positivity together with the red chromogen, which is CK7, and some areas here were CK7 positive, and this area I'll go higher power on it. So here, this is the area near the crushing. Here we can see that there is some maybe CK7 positivity or maybe a blush, to be honest, like we weren't sure, but this is in comparison with the area in the center. This is a benign gland, and then all these are basically the infiltrative tumor cells around. There might be some P63 very rare patchy positivity in this area, but we weren't sure what this area is, to be honest with you. So we did S100 because, of course, it was triple negative. We did ERPR HER2, it was triple negative. And then we did S100 because of the atypical MGA, because we knew that this is S100 positive. And also we did the SOX10 because it's good in triple negative breast cancer. It's a sensitive marker, especially if the GATA3 is patchy positive, not diffuse strongly positive. So going through the SOX10 was positive everywhere, but here this area kind of really lighted up with the SOX10 positivity. Going at higher power, even the cells, this area which was negative for CK7, maybe a bit of blush, maybe a bit of P63, but this area really lighted up the SOX10. And S100 was exactly the same. This area lighted up, and the rest there was also positivity with the S100, which is expected, especially with the background of atypical MGA. It was staining for S100 positive. So given that this pan-keratin was done and this area, the crushed area, was dead negative, so given that this area was dead negative, so then, and the SOX10 S100 was diffusely positive, so other melanoma markers were done to try to see what this area is. So the HMB45 was negative. This is from the middle of the core. The HMB45 was dead negative, but here in this crushed area, the HMB45 was positive. The melan A was patchy and rare cells positive, but the HMB45 was definitely strong positive. This is HMB45 with the red chromogen. So basically, the IHC results in this one was the area which looked like invasive mammary carcinoma, pancreatin CK7 positive. The crushed area with the tumor cells were negative. SOX10 S100 diffuse positive in all areas. P63 patchy positive in the invasive mammary carcinoma. In the crushed tumor cells, rare positivity. GATA3 patchy in both. HMB45 negative in the invasive mammary carcinoma, positive and patchy in the crushed tumor cells. Was positive but way less than the SOX10. Melon A was negative, rare cells positive in the crushed area, and the PRAME was diffusely positive. So basically, what we were sure of is that there is invasive mammary carcinoma that was triple negative with focal area that could represent a typical MGA in the background. But then there was this area of crushed tumor cells that we weren't sure that showed melanocytic differentiation but IHC, but we couldn't characterize it any further. So looking at this case, we went to the EMR and Connecting Ontario, nothing about the history of melanoma in this case, but then multiple questions were raised. Is this lesion close to the skin? Could this be a melanoma, like from the skin extending underneath to the breast parenchyma, and this invasive mammary carcinoma, and this is a collision tumor? Does the patient have any history of melanoma that we don't know about, and it's not in EMR or Connecting Ontario? Or does the patient have any skin lesion anywhere else in the body? So the clinician was notified, and the clinician talked to the patient, and there was no history of melanoma. They also referred the patient to a dermatologist to see if there is any other skin lesions anywhere in her body, and there was no suspicious skin lesion. So overall, they weren't sure exactly what we're dealing with. Are we dealing with invasive mammary carcinoma? What this area of melanocytic differentiation present? Does it represent a collision tumor? Is it metastatic melanoma? Could it be part of the invasive mammary carcinoma that's expressing this? So basically, we didn't know exactly. So, and the clinicians, we couldn't take it further. So the consensus was that let's do partial mastectomy, sentinel lymph node, look at the resection, and see how further we can go on this case, and if we can basically nail it down to what we're dealing with. So this is low power view. So here, this area, we see the areas which looks like on low power, more of rounded length structure, which could be like maybe MGA, which could be the area that was presented in the biopsy, atypical MGA. And then this areas of infiltrative, and then there is this very high grade, poorly differentiated area, and there are areas of necrosis here in the center. Going higher power, there was this infiltrative, which looked basically like the biopsy. It looks like invasive carcinoma. Here, this is also other areas with invasive carcinoma, and some of these glands, which could represent a typical MGA. Higher power, we see also these rounded glands with sometimes single, sometimes multiple layers, which at this point, it's like we have invasive cancer, we have atypical MGA in the background. So the main thing was that what this focus of poorly differentiated area represents. Going higher power view, you can see here, this area which looks like invasive mammary carcinoma with atypical MGA in very close proximity and adjacent to this area, which looks very high grade. Higher power, we see these areas with maybe secretion, atypical MGA probably, and then this is the area with very high nuclear grade. More pictures. And then just going through this area, there was nothing, it's just very ugly tumor, very high grade. Going to higher power, a lot of necrosis in areas, a lot of apoptotic bodies, a lot of mitosis, nothing specific about this area. Going here, this slide was amazing because basically here you see some areas which it looked like the regular, it looked like invasive mammary carcinoma, but then there was this area that I would focus on, and then this area which looked similar, the very high grade component of the tumor. So here, if we look here, we see some areas which on higher power, it looks like matrix producing. So basically we have invasive mammary carcinoma with focal metaplastic features, matrix producing. And then going at higher power view on the area that looked very poorly differentiated, we see these areas, which to be honest with you, I wasn't sure whether this represented tumor that is like, the invasive mammary carcinoma going inside, and this is just like, an area of collision between the two tumors. Are these basically the invasive memory carcinoma that got very poorly differentiated and then it will go into sheets, or what's happening? Here also these areas, in some areas of the tumor, you see these parts which are not just sheets. Actually, they're trying to form maybe fake glandular or maybe ribbons, which if we look at actually the nuclear grade, all the tumor everywhere. So then we did immunes. So ADH, which is again CK7, CK5, P63, as we can see, the invasive memory carcinoma is diffusely positive in the background. This area was dead negative. Multiple keratins were done in this area, and all the keratins were negative. The only thing that was focal and patchy positive was P63 in this area. And here you can see some of the tumor cells, they're actually infiltrating here, and you can see the CK7 positivity of the invasive memory carcinoma going in. This is a higher power view of this area. This is the SOX10. It's diffusely positive. This is the area with the matrix producing. Also, all the tumor was diffusely positive, and this area showed strong diffuse positivity as it was in the biopsy. This is the HMB45. It was also patchy positive within the tumor cells here in this area, but the rest of the tumor, the invasive memory carcinoma, was negative. It was only patchy positive in the area that was very poorly differentiated. So this is the results. This is of the IHC, which basically it was similar to the biopsy. The HMB45 was also patchy positive in the area with the melanocytic differentiation negative, and the rest P63 was patchy positive in both areas, but here was very patchy and focally positive. So then when we're looking at this case, we started thinking about it, I have to say all of us. So this case was brought to consensus and we thought about it. And basically the differential is this. Can this be metaplastic? Because we know that this is invasive memory carcinoma with metaplastic features, which is matrix producing, but could this area be part of metaplastic carcinoma, which can have melanocytic differentiation, which is mentioned in the WHO book, and also in some of the case reports? Or are we dealing with collision tumor? Could this be invasive memory carcinoma? And this is like melanoma, whether metastatic melanoma or very, very rare primary melanoma, which is not even mentioned in the WHO book, only in the literature, that rare primary melanoma can happen with this. Overall, like we thought that we already have a metaplastic, like invasive memory carcinoma with ductal and metaplastic features, and we already have this area with melanocytic differentiation, and we know that melanocytic differentiation can happen, although rarely in metaplastic carcinoma, and given that it was very close proximity, the patient didn't have any previous history of melanoma and nothing currently with the dermatological exam or everything, like we favor that this area represents metaplastic carcinoma with melanocytic differentiation. However, I cannot entirely exclude the possibility of collision tumor. Overall margins were negative. No LVI were seen. 4 lymph nodes, all of them were negative. This case was sent to UHN for expert opinion and molecular testing if it's deemed necessary. So Dr. Berman, he received the case and kindly enough, he did molecular testing where basically there was macro dissected the area with the melanocytic features, and was keratin negative. This was macro dissected separately from the rest of the tumor, which is the invasive memory carcinoma. Both areas showed the same mutation in NF1, TP53, FGFR3 genes were detected, both of them. Both areas showed RB1 copy loss, but there was this TGFR1 fusion, which was seen in component 2, which is the area with the invasive memory carcinoma, and not seen in component 1. So basically, both areas show same mutations, with only one fusion being the gene that was seen in one component and not in the other. So the final diagnosis from the consult report is that overall the features most in keeping with invasive memory carcinoma with metaplastic features with melanocytic differentiation. So these are some of the references. So just follow up on this patient. The patient received adjuvant chemotherapy that was finished September 2023. February of this year, she came to the emerge with severe neck pain. MRI of the spine showed diffuse spinal mets with T9 cord compression. Biopsy of the vertebral body was done at Sunnybrook that showed metastasis with melanocytic differentiation. The patient received a vertebroplasty at Sunnybrook, and then after that followed by radiation. And just when I was looking at the history, at the follow-up of the history. I looked at the report of Dr. Julia Keith at Sunnybrook, and this tumor was dead negative for pan-keratin and only positive for SOX10, S100, focal HMB45, and melon A was very patchy positivity. So when I was looking at the report, of course, Dr. Keith signed it out. Given the history, it's most likely represent mets from breast origin. But to be honest with you, since I'm receiving all these, general, and I'm doing general sign out, we receive all these biopsies. If I received the biopsy from a patient with just a history of invasive mammary carcinoma with melanocytic feature, with metaplastic features, with no mention of this melanocytic differentiation, and then I got a met in the vertebral body that's negative for keratin, positive for all the melanocytic marker, I might have actually went for melanoma, which is very scary to be honest. So I think the take-home message in this, melanocytic differentiation by IHC or even melanin pigment in tumor cell in the breast biopsy doesn't mean melanoma. Metaplastic carcinoma of the breast can have melanocytic differentiation by IHC, or it can be melanosis in the breast. Melanocytic differentiation, I believe that melanocytic differentiation metaplastic carcinoma is an underdiagnosed entity. I've never done melanocytic markers by IHC in any of the breast biopsies except two, which was this case and case 2, which if we have time, I can present it later. But otherwise, we don't do it. So maybe this actually, it's more common than we know, but because we don't do it, we don't know. I think this was to me after I read the history and the follow-up, any weird IHC of any tumor, any morphological heterogeneity. I learned this during my residency, my fellowship. I try to mention it, but especially after this case, I'll try to mention it more and more. Because this T9 biopsy that was done, if there was no mention of melanocytic differentiation in the breast biopsy, I think I'm one of the people that I might just find it out as metastatic melanoma without knowing, because I didn't know previously that metaplastic carcinoma can have melanocytic differentiation. And I think, of course, patient history, the clinical impression to them, it was a single tumor, it was breast cancer, and of course, the imaging are very important to make the final diagnosis. And that is the end of my presentation.
Thank you so much, Dr. Bowles. What a challenging case that is. Very interesting immunochemistry patterns as well. Does anyone have any questions they'd like to ask about this case? Well, thank you very much. If not, we'll move on to the final case of the day. That's going to be Dr. Yali Xie from Trillium Health Partners.
Hi, everybody. My name is Yali Xie. I'm a staff pathology at THP. I'm quite new in the have limited experience with the breast. I bring an interesting case, quite challenging. So my just interested in seeing most people how you guys think in our breast community, and any input will be greatly appreciated. So this is a 56 years old female.
Oh, sorry, Yali. Before you get going with your presentation, can I just ask you to put it into presentation mode so we can see your slides a little bit better?
Sorry, what's going on? Oh, the full.
Yes,
okay.
yeah, please, yeah. Thank you.
How about now?
That's great. Thank you.
Oh, okay. Sorry about that. Kind of. Okay. So this is a 56 years old female, and had the image shows a solid lesion and about a 2.6 centimeter size. And a biopsy was performed and shows a typical papillary lesion with a loss of myelopathic cells. And the pathologist diagnosis like in the differential diagnosis way, and considering invasive carcinoma, encapsulated papillary carcinoma, and also maybe also solid papillary carcinoma. So the excision is performed. So what I got, the tumor growth rate is about 33 millimeter growth rate. So this is the image I would like to show you. This is a main tumor I got. So this at the beginning seems a wild circumscribed lesion, and there's always a little ear hanging out. And the triple scan shows that there's no myelopathic cells. When we zoom in, so we can see there's a kind of a solid papillary appearance with a delicate fibrovascular core here. So from the image, probably it's no hard to diagnose it. This is look like a solid papillary carcinoma. So let's see I zoom in this area. So you can you can see here, this quite another papillary lesion, just adjacent to this big one. And this is, I just want to show you, so the morphology difference. So this is the solid papillary carcinoma, but this morphology, the papillary, kind of different. This kind of like a desmoplastic change, but I'm not very sure. And we did the immuno here, so this shows there's no myopathial cells. So adjacent this solid papillary SPC tumor, so there's a next section, there shows us multiple clusters of tumor cells. And this cluster cells also show the papillary. So I just zoom in here. So this area, so when we zoom in, this see the papillary, just like the ear hanging out portion. And this area, we can see the micropapillary, even some micropapillary morphology here. So then we do the immuno, we can see this all the little things in the background is a conventional ductal carcinoma in situ. And this below this part, all this nice, it's a papillary lesion, but there's no myopathial cells. So there's another close view here. So we can see all this nice extending and also these things and all around here. This adjacent section as well. So this shows similar things, conventional DCIs and also invasive components. This also for the DCIs showed also papillary and micropapillary features with necrosis. So the immuno, we can see this DCIS conventional type, and this is papillary in like lost myopathial cells. So this is sorry about that. So this one go back. So the differential diagnosis. So I showing around in our group. So basically come out 3 different kind of opinion there. Some people think probably it's SPC with invasion and just with invasive carcinoma. Someone think probably just a displacement due to the biopsy. And their third opinion is probably multifocal invasive carcinoma with papillary features. So now bring this case to everybody, see how everybody thinking here. So you can type in the chat. So like question 1 is like what you think is the choice 1, choice 2, or choice 3. So I just as long as you're typing, so I just go along. So about this continuing. So actually, so this is beginning I mentioned the morphology is this area. So this related multiple sections is this big tumor, and adjacent section this like multiple clusters is in this area is section 8, and this totally long, this will be 11 millimeters. So this size, greater dimension about 3.5 between to 1.5 millimeter. But these intervals between these clusters is about 1.2 to 2 millimeters, definitely less 0.5 centimeters here. And adjacent like 7 and 3 show similars, and with this papillary lesion, and with in the background a conventional ductal carcinoma in situ. So now we know this part is most likely invasive carcinoma to us. So then next question is how we staging this tumor. So this one, so the morphology from here, and also this hanging ear show the similar morphology and kind of different from the SPC tumor. And these things like, if this is your case, so how would you measure this size? So like you measure, like go to the 1C, or you think probably 1B. So there's things I want to mention. So section A and 8, when I put them together, they are exactly kind of overlapping certain area. But section 3 is landing somewhere, but it can't be definitive because this cut perpendicularly. So this the second question. So your opinion will be appreciated. And the third question is, so the blue circle area. So would you think this invasive carcinoma And if you think it is, would you think this is associated with SPC or this part invasive carcinoma? So this, I just, whatever you think. So I would like most people in our society, how people will think about this case. So then this last question is this one. As I mentioned at the beginning, there's some papillary architectures here, but this focal area is kind of a micropapillary appearance here. So if this is your case, would you mention the micropapillary features here? So this case end up, so we sent to UHN. Sorry about it. Okay. Because of different opinion in the group, sent to UHN. So eventually, the UHN consult diagnosis come back. It's called a multifocal invasive carcinoma with papillary features. And this one, and also solid papillary carcinoma in situ and EPC as well. And also ductal carcinoma in situ, basically. And the pathology, they consider PT1A. But because this grading actually because they don't have the map what we have. I guess that's why probably it go to all the one PT like a PT1A here. But when I come back eventually for the final report, I count this because 7 and 8 exactly next each other. All the tumor I try to map my sections according to color code, also the auto contours together, and the 7, 8 exactly overlapping. This part exactly overlapping together. So that's why I count them together. So I consult with a group, but commonly people think probably we should go to the UHN expert opinion. So maybe just go to multiple, just call all the things multifocal and the PT1A. But for somehow, once I realized these two seconds exactly next each other, I feel I can't really go to PT1A. So eventually I sign out this as a PT1B. But however, this is also like in the AJCC. So we, the general rule, when this lies 5 millimeters, we generally consider as a one tumor. So in AJCC rule, but the things we don't have much experience with the papillary invasive papillary carcinoma. The people say it's like on WH book is extremely rare tumors. So in this way, just if anybody have experience with this, so why this could be as a like an exception to after the 0.5 centimeter rules. We try contact the UHN, but anyway, we didn't get answer back about these questions. So this the final diagnosis is here. So this is something I just go through some literature. So briefly, I just briefly summarize what I learned through these cases. So generally the solid papillary carcinoma, so it can be well circumscribed. Usually the definition is a well circumscribed solid growth pattern, delicate fibrovascular course. So it could be in situ or invasive now in the WHO classification. So, but this one is commonly about 1% of all the breast cancers, and commonly it's at age 70s, but more than 50 is rare. So my patient is 56, but when the diagnosis like 90% is still like localized, but well still there's 8% with metastasis. So in this kind of case, so invasive the components, so generally can diagnose with the conventional ductal carcinoma and the lobular carcinoma or cribriform and the tubular carcinoma. Rarely this invasive solid papillary patterns. This one, so you can see this from the different papers. So this FET invasion here, and the common ERPR and also HER2 negative. Commonly, this also neuroendocrine feature can present. So in my case, seems there's my case, the invasive component pattern doesn't match any of them. I'm not sure if anybody has experience like this also has like a papillary features with just a solid papillary carcinoma with like papillary features specifically. I searched later, I didn't find something like a really typical for can match my case. If anybody know, let me know. So any input will come here. And this another thing is invasive papillary carcinoma with this also with a fibrovascular cross comes generally like match the papillary like definition with covered neoplastic epithelium. This one is WSO cause extremely rare, but some literature says about 0.5% of invasive carcinoma. This is just a variation from extremely rare and 0.5% somebody reported. And this is slow growing tumors and with good prognosis commonly. Oh, sorry. And differentials say from like invasive micropapillary carcinoma and SPC and also EPC. So basically, because of limited time, so I just prepared this much for, and the rest of me, I just would like to throw some if anybody put some discussion will be great. And I especially thanks all the pathology in our group for their really dedicated contribution on this case and help as well.
Thank you very much, Dr. Shi. I think like you, I'd probably be more inclined to combine kind of the tumors in slide A8 together and make that one tumor. So I don't know what anyone else would do, if anyone like to have any input or if they've got any questions.
Yeah, I put here. Yeah.
So if not, I think in the interest of time, we'll conclude this meeting. I want to thank Dr. Gabriela Kuba for her excellent lecture on vascular lesions of the breast, and the presenters who showcase their interesting cases today. Thank you so much. And to everyone who's attending this meeting, please make sure that you do fill out the survey. Sharon, do you have anything else to add?
Everything is good. I just want to say that when you send the case for consultation, it's a good practice to send the grossing diagram so that your consultant will be able to see the three-dimensional relationship between the different blocks.
Absolutely, I couldn't agree more. It's very difficult to do without the tumor map.
Yeah.
Okay.
But even like that, so this is one section. This in the middle one, this in one section. Just on one slide, this one.
That's right, but you know, it could be that this all are like almost like rays that are like a sun, and they are radiating away from a central focus. And on this particular slide, it appears like 3. So I think that it's really important to take it all together and then do your best to make that diagnosis. So it is important to know the relationship. I understand that you have it here on a single slide, but it depends how it will reflect itself before and after.
So Shannon, just one quick question. If without these sections, only this section exists beside this tumor, would you consider this as one tumor or different tumors?
So you think that they are one after the other, one is medial to the other?
Yeah, my question is ignore 7 and 3. If there's only this section present adjacent this lesion, would you consider this is one lesion or multiple lesion?
I think that this is possibly different lesions because they look very well defined. But on the other hand, this is also a very subjective call.
How about this? Would you consider it's invasion or not?
I cannot see it at all. I mean, it's too small for me. So I just, it's impossible for me to even look at this area.
Yeah, this is the whole area.
To me, it looks like you have hemosiderin around it. And is that right? Is there any?
No, this is the triple stain. So we have the P63 and the myosin. So this is no hemosiderin. This
Look,
is the brown stain.
the aged knee looks very inflammatory. It's inflamed, has this myxoid stroma. I just wonder if this is part of a biopsy site. I don't think that I am able to make this distinction based on these images. I'm sorry.
Yeah, thank you for the effort. Thank you.
So in
I
that case,
agree. It looks very. Sorry, I missed
No.
most of the presentations. I had to go for Frozen, but just on the images shown there, it looks like there's a lot of reactive changes going on that one would have to consider prior needling procedure and leading to disruption. But it's hard to see on just the screen there.
so thank you very much. Thank you very much, everyone. To our presenters, our moderators, Dr. Sharon Nofech-Mozes and Anna Marie Mulligan. And thank you for everyone for participating. Again, please remember to fill your survey. Thank you.